Hi everyone, thanks for watching. In this video, I'm going to talk about ultrasound of the shoulder with a focus on dislocations and intraarticular injections for reductions. The easiest way to scan the glenohumeral joint is from behind. We typically will use the curvilinear probe for this, but I suppose you could use the linear probe in someone very thin. You'll put your probe in the transverse plane just inferior to the scapular spine. The posterior scapula has a prominent and easily palpable ridge called the scapular spine. We will place our probe just underneath this landmark and look for the rounded humeral head. We're going to put our probe right about here. The humeral head is usually the most obvious sonographic structure, and then from there you can fan until we find the glenoid and scapular neck. This is our standard view of the posterior shoulder. In the center of the screen is the rounded humeral head. To screen right of the humeral head, you can see the glenoid rim. In the near field, which is the posterior shoulder, and closer to the probe, we can see infraspinatus. To screen left and lateral to the humeral head and joint, we can see the deltoid muscle. With labels added, we can see infraspinatus in that near field. Remember, we're looking just under the scapular spine, and so this muscle is pretty appropriately named and easy to remember. If we were to scan just above the scapular spine, we would find the also appropriately named supraspinatus. A very useful trick for finding your location and also for confirming a successful reduction is to internally and externally rotate the patient's shoulder while keeping your probe as still as possible. This will show the humeral head seated in the glenoid fossa. I also want to point out that the second deeper muscle you see in this clip is teres minor, which lies just deep to infraspinatus. This is a still of a shoulder dislocation. Take a second to try and make sense of what is going on. Is this an anterior or posterior shoulder dislocation? Hopefully you settled on anterior because this is in fact an anterior shoulder dislocation. The humeral head is displaced anteriorly relative to the glenoid. Our probe is on the posterior shoulder, and so objects that are further away from the probe and are located in the far field of our image are more anatomically anterior. In the joint we can see a hemarthrosis, and we can see infraspinatus is now stretched around the glenoid rim. We can see that here. Conversely, this is a somewhat subtle posterior dislocation. These are far more difficult to identify clinically, radiographically, and even sonographically. The giveaway in this clip is how far back the posterior humeral head is compared to the most posterior aspect of the glenoid. You can also see how in this particular case, the patient is still able to rotate their shoulder, despite it being dislocated, making this clinically difficult to identify. Putting a posterior dislocation next to a normal shoulder, the posterior dislocation is much more obvious. For this reason, I would recommend looking at all of your dislocated shoulders with ultrasound to get a better sense of normal versus abnormal. Remember, you can always compare to the contralateral shoulder if you need a normal shoulder for comparison. Now that we've explored the glenohumeral joint, it's pretty straightforward to inject it to facilitate a relatively painless reduction. While we have our view, we'll insert our needle lateral to our probe at an angle pointed back towards the shoulder joint, from lateral to medial. What this will look like on your screen is a needle coming from the near field from lateral to medial. The target is the area lateral to the glenoid fossa that has been vacated by the humeral head. Once you enter the joint, you can often aspirate some hemarthrosis, confirming your location. You can then inject your anesthetic of choice and perform your reduction. Don't forget to confirm your reduction with ultrasound. I don't do therapeutic shoulder injections, but the same approach can be used for these as well as for diagnostic shoulder arthrocentesis as well. Instead of targeting the empty glenoid fossa, you're just going to target the hypoechoic shoulder effusion. Thanks for watching. Check out the rest of our website for videos on all things POCUS and emergency medicine, including our growing library of how-to videos for common nerve blocks.